Well, hello, hello, hello. Hi.
Hey, Jonathan, how are you tonight?
I'm good. How about you, Nadine?
I am good. Glad that I'm not outside in the rain at the moment.
It's so freaking hot outside.
I love
um,
it, I love it. I love
I,
it.
I'm not going to comment on that. But I'm glad that you were enjoying
Thank
it.
you.
So today we have an amazing guest to talk to us about a very important clinic here at I'm gonna start saying at our county before we our guest comes up. But of course, as always, we want to do our usual acknowledgments and recognitions, and that is that Black Lives Matter. And actually, a couple of days ago was Brianna Taylor's birthday, and she is still, and everyone else is still waiting for justice for her. So we are hopefully with things that have been happening, especially since the charges pressed to the murder of George Floyd. Hopefully, justice will come soon or sooner than later, and we are still waiting. And we have been waiting for a long time. But yes, so, my name is Jonathan Rodriguez. I'm the Youth and Health Resource Center Coordinator for Bergstein's Matters, and I use he, him, and ill pronouns. And with me,
My name is Nadine, and I am the liaison for community engagement with Berks Teens Matter, and I use they and their pronouns.
and since we got that out of the way, you know us, but who you might not know, and hopefully you will get to know what they do better is our guest today. And as this is Askable Adults Live, the show where we talk about sex ed, community, and resources. And since we are also in one of the best months, because Happy Pride
Pride
Month.
Month.
We would like to give it up or give the floor to the medical director of the Transgender Medicine and Surgery Program at Reading Hospital, Dr. Ashley Brandt. Hi, Dr. Brandt.
Hi, everybody. How are you both doing?
All good.
Good.
Trying not to fangirl.
Yes, I must say I'm happy about the rain. I have a garden, a big garden for the first time this year, and I'm very happy it's raining. But working in that over the weekend was not the most pleasant experience. So
It was like probably being in a steam room or something.
it was, especially since I was in head to toe long sleeve since I burned. So yeah, it was very hot. But I'm very honored that I'm here. So thank you both so much.
Of course. This is long overdue. We met Dr. Brandt a couple of months ago when she gave us a tour through the Transgender Clinic. And speaking of which, I think this might be some news for some, but yes, there is a Transgender Clinic at Reading. Can you tell us a little bit about how the clinic came to be?
Yeah, of course. So a little background on the clinic. It started a little while actually before I came to Reading and Tower Health. It was sort of an initiative started by the hospital wanting to do more community outreach and understanding that there was a large need, particularly in this area, since Philadelphia is very saturated with a lot of gender affirming care. Not that there can never be too much, but you have the Einstein Pride Clinic, you have the Mazzoni Center, a number of surgeons in Philadelphia or people starting to do procedures and care in Philadelphia. And so there was nothing out in this western or more western part of the state. And so the hospital reached out to my department chair, who started a program initially just for hormones and just routine gynecologic care. And then my department chair actually was my former residency director at Hahnemann when I was doing OBGYN, and I completed one of the first gender affirming surgical fellowships in the country at Hahnemann after residency when it closed. And, he brought me out this way to continue really expanding the clinic at Reading Hospital, offering not only gender affirming medical therapy, routine care for anybody on the gender identity spectrum, but also to really start offering surgical therapy here initially at Reading, and then extending that all the way down towards Philadelphia at Phoenixville and Chestnut Hill hospitals. So,
Wow, that's amazing.
That's the plan. COVID has derailed and sort of put a lot of that, sort of temporarily back and delayed, but it is still underway, just a little on back.
Like everything, I think COVID has done. It did its work to kind of put the world,
put a lot of things on pause.
Yes, exactly. So
you mentioned a couple of the services, but can you tell us what type of services are offered at the clinic?
Yeah, so I will preface this by saying, so unfortunately, the title of the clinic is still, when patients try and schedule an appointment, it is still under this overhead banner of the Women's Health Center, since it is the gynecologic center in the hospital that was initially one of our OBGYN resident service lines. We're trying to, there was no special room or place to put the clinic when it was initially started, and so they weren't sure how many patients it'd have initially, so they just started this within that center. So fortunately, we'll be looking to outsource office space, so it's no longer in a women's health center, which colloquially can be problematic, obviously more for my transmasculine patients, who sitting in an office of pregnant women obviously may or may not be the most ideal experience, but the staff is great. The patients are great. We have probably over 200 patients now, and it grows every single week with calls and things like that. So it's currently in that women's health center, but our services, like I said, we offer, I really target patients. Since my specialty is background in OBGYN, I initially started really doing hormone therapy after residency, and then doing routine, well screening for trans feminine individuals, transmasculine individuals, and any non-binary folk or gender non-conforming folk, anywhere on that spectrum. That's more of, a body part directed screening. So regardless of your gender identity, it's more of a body part directed screening and testing, whether you're pre-op or post-op. Like, try and target screening that's appropriate for the organs that you have, in addition, and being sensitive to the gender that patients identify as. And then additionally, the surgery was the big addition that has been here. Okay. So surgery for both transmasculine and transfeminine folk. So all types of top surgery, breast augmentation, mastectomy, metoidioplasty, hysterectomy, vaginoplasty, orchiectomy. I am trained in phalloplasty, but it's a very complicated procedure, and I would like to have a microvascular surgeon here and possibly another gender affirming surgeon here before I really start to undertake that. My biggest goals are really establishing a pretty streamlined vaginoplasty track before really focusing on the phalloplasty, since that's just a lot more complicated and a lot more involved.
For folks that might not be too familiar with, Nadia, are you talking? I'm sorry.
I wasn't talking, but I think I was going to say exactly what you were going to say.
Go for it.
For folks who are not familiar with the terminology, would you be willing to define that terminology of vaginoplasty and phalloplasty and etc.?
Absolutely. So mastectomy is typically referred to for transmasculine folks or non-binary folks who are assigned female at birth, and who, wants to remove the breast tissue to a more male appearing chest or a more gender neutral appearing chest. That's really in the community is more termed as top surgery. For trans feminine folk or non-binary folk that want enhanced breasts, it's, breast augmentation or, a boob job is what, a lot of people in the cis community will refer to it as, is that procedure. But anything from the waist up is kind of referred to as top surgery. Anything from the waist down is termed bottom surgery. So the vaginoplasty, again, more for trans feminine individuals that, would like, the creation of a new vagina instead of having, the, male anatomy that they were assigned at birth, to have, female appearing vulva, to have a vagina that they can either use for penetrative sex or just so they can have a functional vagina. The metoidioplasty is essentially creating, it's for transmasculine folks. It's used for essentially to void while standing. So it's creating essentially a micro penis that patients can use to void while standing. You can create a scrotum, you can close the vagina, unfortunately, it doesn't have the length that it can be used for sex, but it still has sensation. Phalloplasty is creating a fully functional male appearing phallus that you can both, ideally it's an adult size male phallus, and you can create, again, a scrotum. You can use prosthetics to help with penetrative sex and pee while standing. Obviously, it sounds complicated, and it's involved. It's because it's very, very complicated and very involved. But those are sort of the breakdown of terms for what the surgeries are referred to as.
Thank you for that.
It's so amazing that that it exists. That all these procedures exist, and the last when we met a couple of months ago, you mentioned that although there are risks undergoing the different procedures, there are some that are, there are risks, but they are pretty safe inside the medical field and all this. You also mentioned that right now the clinic is not necessarily for kids or teens, but so does the clinic offer puberty blockers or not?
Not yet.
Not yet.
And the reason is sort of threefold right now. One, because my fellowship training is in the surgical, like gender affirming surgery.
Mm-hmm.
As I start to build up a large surgical practice, and that is really even growing quite exponentially, even in being here through COVID, not really be able to market because of COVID as much as I wanted to, and do a lot of community outreach in the ways that I wanted to. My focus, I want to really, because those surgeries are very involved, I want to kind of eventually move more towards focusing on the surgical side.
Okay.
I will still continue to manage hormones and do routine care, particularly for the patients that I operate on. But I eventually want to add another provider. My fiance is a midwife, actually, and she's very interested in the hormone therapy aspect. And so adding someone like that to the practice as we continue to grow for hormones, for hormone management for patients who don't want surgery or aren't ready for surgery, I think would be great. And then eventually potentially add someone on.
It went away. Don't worry. We lost the audio, but it's gonna come up in a little bit. You're muted. Yes.
Sorry, I realized my computer went to sleep. So there we go.
Don't worry.
Just logged me off very suddenly. So ideally, as the center grows and as we add more offices and things like that, I would, like to consider puberty blockers, but I personally wouldn't be prescribing them, only because pediatric and adolescent gender affirming care is a lot more complicated, both socially. It's obviously come under a lot of fire politically right now, and so I don't want to. While I can be the jack of all trades, I think we are at a point in the field where there are enough people starting to offer and really specialize in some of the care that I want the adolescent and pediatric patients to get 100% of the provider's attention, and I won't be able to do that and do surgery as safely or effectively as I want. Kind of the additional reason is I get referrals from CHOP and work very closely with CHOP, and I don't want to compete. I don't want to bite the hand that feeds me. So CHOP is a very, very well-oiled machine. They do a phenomenal job. Obviously, they're a little bit farther away, which could be a downside for people in Berks County, but a lot of patients come from all over the country sometimes to see CHOP. I know. So eventually, I mean, we'll see. It all depends on how the center grows, but I don't want to, like I said, I don't want to bite the hand that feeds.
No, and not only that, but you're only one person, and of course you have a team, but how thin can you stretch before you stop being as good as you are right now at your job?
Right.
So hopefully, as the center grows, other specialties will be included, but not everything has to be has to come from you. That's
right.
Totally valid.
Exactly. And so, as you said, as the center grows, that would be a conversation that would have potentially develop a more referral stream with CHOP, or have a relationship with CHOP, or find a way to sort of connect CHOP and St. Chris. So it's a more of a symbiotic relationship and not a competitive one. But there's so many politics involved in care and medicine these days. But I right now, especially for pediatric and adolescent, I really like people who can have the appropriate team for social services to address parental concerns, to really address and assess the child, and have time for like hour-long visits and really assess those things. And the team, I think I'm not trained for that. And so I don't want to masquerade as someone who's learning blockers medically is very simple, but it's knowing how to really navigate the family dynamics, the social situations, discerning between, normal adolescent and pediatric behavior, and the role of like sexuality, the role of gender identity. It's like, that's just not what my background and training is. And so while the medicine aspect is really easy, the dosing, knowing the side effects, knowing the hormones, understanding that social component and navigating the nuances of that, and legally, and, laws in different states, I leave it to the experts, and we'll hopefully add someone on and a team on that could do that. But
I really appreciate your commitment to the people that you serve and the quality of the service that you offer, to not want to try as much as, we all might want to say, oh, we want to be able to make sure that everybody has access, to do it in a process that is thoughtful and planned, and ensuring the best outcomes for the people that are being served.
Thank
is
you.
Really, really, really important.
Thank you. Yeah. And it's, I've seen, young kids that are 14, 15 years old who weren't really patients, who are really more ready to start the hormones themselves, and who've been established with a therapist for quite some time. Obviously legally in the state of Pennsylvania and most states, they require a therapist's letter under the age of 18 before starting hormones. At least in the state of PA. I'm not sure what all states, but I'm pretty sure that's pretty standard across the country, at least where it's currently still legal, which is a whole separate conversation.
A whole nother show.
Unfortunately. But, it's just, I think part of being good in medicine, and part of being just a good advocate for the community, is knowing when to refer, and knowing when you can't, even though you want to, and knowing that you probably could. Just because you can doesn't mean you should.
I like that. Very well said.
Yeah, I'm a huge Jurassic Park fan, and I think that was like the theme of that. So I think, again, just because you can doesn't mean you should. And so there are a lot of people that I've networked with in the city and the surrounding area and across the country that can provide great care for patients, particularly teens and adolescents. And they deserve that. They really deserve that.
Yeah.
Speaking of which, it's also important. We've been focusing on one type of transition, which is the transition that we will be focusing today. But it's important to know that not every transgender person wants to get surgery. That doesn't make their identity less valid. There's actually three types of transition. Legal, when a person changes their gender identity and names in their legal documents. There's the social transition, when a person comes out to themselves as well as others as the truest self. They wear different clothes, they change their hairstyle. They essentially start living as the true identity, and of course using the pronouns that work for them. And of course, the one that we've been talking today is the medical, which is when a person undergoes hormone therapy and may also undergo gender affirming surgery. But again, the surgery doesn't automatically makes a person more or less transgender, which is, I think, a perspective that a lot of people still have to this day, still has, that, oh, are you transgender? Did you and of course they don't say it this way, but did you undergo surgery? And that's not necessarily correct, because their identities are not dependent on whatever they're doing with their lives aside of existing. But when a person undergoes a medical transition or the surgeries, what are the steps that they need to go through when they first come to the clinic?
Okay. I first want to really applaud you for really breaking down the more intricate nature of transition. And it's not, I think, as you said, a lot of people think it's this linear, I come out and then I start hormones and then I get surgery. And then it's, while a large percentage of patients do undergo affirmation surgery in some way, I think it's really important that you differentiate it, as you just did, the fact that it's not this linear process. And there can be, maybe some people may want to stop with the social transition or the legal transition, or hormones, or then want to stop hormones, and and because they're happy with the changes that they have and they don't like the effects, or then want to years down the line move towards surgery, or not have surgery because they're happy with how they present just from hormones or just from the social transition. So I think, and I do want to also say, is that any patient, regardless of whether they're interested in hormones or surgery, our center is open to all patients who identify as transgender or non-binary or gender non-conforming, because a lot of patients just need to sit down and talk to somebody and just want to know that there's an ally in the community. And so even though I provide medical services and surgical services, a large part of my background is in doing routine screening. And again, patients, regardless of your gender identity, need routine health maintenance. And so our office is obviously a very gender affirming office. And so even though patients, say I'm good with a social transition, patients may still feel very uncomfortable just going to a regular doctor because they're not affirming, they're not of community. And so all of those patients are welcome in our office. So awesome. First of all,
that's a really big first of all. So thank you for breaking that down.
Yeah, I think that's a huge, I've seen patients like, I want surgery years down the line. I'm like, great, we can still keep having a conversation. That's important. I personally think the more visits that I have with someone, especially before starting hormones, and even more importantly, before undergoing surgery, because they're big life-changing things. So I think the more conversations I have with people about expectations of surgery, complications of surgery, what to expect in the post-op recovery, like what, bodies look like. I mean, there's identifying normal and the variety of that in, the cis world. And then, you can't compare cis worlds to post-op, trans world. And so I think the more conversations you have with people, and and the way you set expectations for how you're going to feel, how things are going to look, the better off that care and the surgical course and the medical course will go for patients.
Yeah, absolutely.
As far as the visit that you mentioned, so you said sort of what to expect at the first visit. So my pronouns are she, hers. I identified for a long time as cis, still mainly identify as cis, but I'm more gender fluid in presentation. My partner, like I said, I'm lesbian female, so I'm recently engaged, which is great. great. We met.
Congratulations.
We're like one of the few couples that didn't get that stayed together. Actually, our relationship did excellent with COVID, and kind of we got engaged before we dated. Really, is what we say. We've been married before we dated because we couldn't do anything. But so I am very, very open with patients about my role in the community and my identity. I've been very active as a volunteer and socially in the LGBT community in Philadelphia and across the country for a long time. So patients will see me at every visit. They'll see my nurse coordinator, Tina, at every visit. But being a member of the community and realizing one of the biggest ways to decrease these barriers in patient care is through education. And what's the best way to educate someone? Then, like, do I think people can do it better? Sure, but like I'm the expert here. So to educate residents, like family medicine residents, OB residents, plastics fellows, nurse practitioners, midwives, PAs that are interested in providing gender affirming care is really the way that you reduce these vast disparities that people have when they go see a provider who may or may not be an expert. If they're if some of my residents go and practice in Texas, that, hey, I, saw a lot of this in residency. I treated a lot of patients in residency, and I know how to, talk to patients, because that's 90% of the battle is being familiar with the language, being familiar with the social struggles in the community, and the fights that, we all have to face that, so patients may or may not see some of those residents at the center at visits with me. And I always give them the option of, what their comfort level is. Sometimes I will always be there guiding the conversation. If sometimes the residents need the conversation, but I will always be there and really fill in the blanks. And I'm 100% responsible for and controlled for care. And for surgery, that is most certainly true. So I never really do an exam at a first visit unless it's a surgical consult right out of the gates and they come with everything ready. So it's really an introduction to the service line. We have a questionnaire that we fill out, sort of talking about a patient's history, gender identity, sexual orientation, partners, really breaking down a lot of things that people may be hesitant to talk about in person. It's sometimes easier to have things on paper. And we'll just really get a basic history of the story and then really assess what a patient is there for. And most visits are a new patient visit is typically anywhere between a half hour and an hour. Okay. Surgical consults are really 30 minutes to an hour as well. And any follow-ups for hormones, telehealth has been really great with this. So I give patients the option for telehealth for visits, since transportation may be an issue for some patients. So that is never an issue. If someone wants to just check in telehealth, hey, hormones are going great. I'm great. My mood's stable. I'm in a safe environment. I'm safe with my partner. I'm doing awesome. Just need these refills. Cool. And so
I like that you mentioned, I'm safe. I'm safe with my partner. I think that's very important to having the, because I don't know if doctors in general are actually asking those questions. Are you safe? Are you safe where you are? Are you comfortable where you are? And especially, when we're talking about transgender folks, it's not only how is the process going, but how is your environment responding to that process. So wow, thank you for that.
Yeah, I think OBs by trade do a much better job of intimate partner violence screening. Yeah. More so than any other specialty. Family practice probably does as well, but it's one of the things that we're really, it's kind of ingrained in you. And again, being a member of the community, really understanding, again, the social struggles of friends, partners, personally, knowing those statistics of intimate partner violence, sexual assault, rape for people, particularly, trans women of color, really affect those rates are disproportionately affected. So I think always addressing those situations and offering that safe space for people to talk about that is, surgery is important, don't get me wrong, but you're not going to have a good surgical outcome if you're not in a safe, environment at home, if your social situation isn't optimal, surgery is going to be, it's a hard recovery at baseline. And so that's a huge part, I think, of having a successful surgical course and medical course and just life.
Yeah. I agree. Nadine, were you gonna say something?
No, I don't know that I was going to say something, but I was just thinking just how nice it is to hear you talk about the whole person.
I'm an osteopathic physician, so it's been
there, the truth comes out now.
It does. A proud PCOM graduate. So ironically, all of the gender affirming surgeons, at least the main ones in the Philadelphia area, are all PCOM graduates.
Oh, wow.
Interesting. I can't say all of them have that same philosophy, by the way, but I find it very interesting, actually.
Yeah.
The osteopath and me talking about the holistic patient care.
Yes.
Yeah, I think that's something that should become more common, hopefully.
We're trying. I think medical education is really trying, and for the first times, they're really starting to address these. A lot of initiatives regarding racism in medicine, social and ethnic and socioeconomic disparities in medicine, gender inequity. I think these are conversations that I would never imagine seeing published like in mainstream medical literature and the AMA, the AOA, American College of OBGYN, the American College of Surgeons, publishing formal statements on how racism in medicine is real and bad, how gender inequity in medicine is bad, and like sexual misconduct is bad. And so I think these are things that have been happening for a long time in medicine. And now we're at this big, obvious, on a national level, this big social, crunch time where these issues are really coming to the fore. They've always been at the fore, just people were not talking about them, and mainstream media were not addressing them in the ways that they needed to be. But it's 100% especially in something like gender affirming care and even obstetrics. I mean, these are issues in orthopedic surgery. Is it as relevant? Sure, it's of course relevant, but not in the same way. And I think when you're talking about family medicine, gender affirming care in those contexts, in surgery, in all of those things, that has to be part of the conversation. The medicine part is not challenging. Hormones are hormones. Like we've been giving hormones for years for multiple different conditions, for different ages, precocious puberty, for menopause, for contraception. That's not hard. The surgery is obviously a lot more technical, but with enough training and experience, like you can be good at that. But it's really, I think, understanding the social history and the current social situation of the patient population that you serve. And I think that, this is a hot topic in plastic surgery now. Like every plastic surgeon just thinks it's so cool. And to me, as an LGBT community member, I think that's great. But the interest is not because they're really interested in helping this really underserved patient population. They're interested because it's a really cool, brand new surgery. And so again, going back to like, just because you can doesn't mean you should. And I think we're at a situation now, and I've seen a lot of, surgical results from people in the area that are like, oh yeah, I can do transgender surgery. Like I was trained to do mastectomies, trained to do breast augmentations, and the results don't look great, not because they're not great surgeons, but because they may not be aware of certain nuances in the procedure. They're not, aware of certain social aspects of patient care. It's not enough anymore, I think, to just know how to do the procedure. I think there's enough of us out there now that patients really will self-select surgeons and really hopefully pick people, not just surgeons, but, medical providers that really care about advocating for the community on not just their medical professional level. I'll take my soapbox now about that. But
thank you.
That's great. That's so great.
It drives me crazy. I'm torn because I'm like, oh, it's so great that people are interested. I'm like,
no worry. So we're running a little bit over time, but I do have a question that I'm very interested in knowing. How has the community reacted to the clinic or having the clinic there?
I think very, very positively. Unfortunately, I have a connection with the LGBT Center of Reading with Michelle, who's been very, very excited. A lot of therapists in the area have been very relieved. I was hoping before COVID to do a lot more social networking. to a lot of areas in the center. Planned Parenthood has reached out. So I think patients are very, very happy that the service line is here. And like I said, I hope to extend it to the Philadelphia area, all the way down, 422 effectively, and maybe even a little bit further west. But I think people are very, very happy for the most part.
That's what I kind of wanted to hear that specific answer, because I was a little bit afraid of if there were backlash or something like that based on certain things from the county, not necessarily the city.
Well, I can't say the county's particularly thrilled, but I don't think the county knows that I'm here exactly. So, I mean, this is also a service line that doesn't need to be put on a billboard.
Mm-hmm.
So, Tower, for example, on their homepage, like, has an advertisement for, LGBT, like for Pride Month. They have a flag, flying just outside the cafeteria. They wanted to fly it outside of the hospital, but I think a couple of years ago, the previous mayor did not like that so much.
Mm-hmm. My
understanding, the current mayor, at least on his page right now, is his personal page, I believe, has a lot of LGBT support and acknowledge Pride Month. So I've not met the new mayor, but my understanding is that he's pretty woke, so to speak, and cutting edge with that. But I mean, you're never going to make everybody happy. I grew up in an area more rural than this. And so I'm not, patients need care. And whether people want to acknowledge that or not, it's kind of really up to them. I'm not going to be throwing billboards up from here all down 76 because I don't need to.
Yeah.
It's word of mouth travels fast. You speak at LGBT, centers, locations, conferences where, I'm speaking at the Trans Wellness Conference this year. And so if you know how to find the community and outreach to them, that is enough. We'll hopefully eventually have a website sort of talking and streamlining our service line. But again, COVID and the financial situation of Tower, which is obviously public information that people have seen at Reading Eagle, and turning over of, the CEO and the president of the hospital have sort of thrown things in flux. So I'm not going to be banging on the door asking for that right now while they're trying to figure out all this stuff in a much larger leadership role, but it'll be something I think that'll eventually happen, especially as it grows. So Tower has definitely made some progress, and Berks County is very red. It's not a bad thing, but it's, the patients are grateful.
Yeah.
The rest of the population, if they're angry, I don't really care.
Mm-hmm. Yeah, that's awesome.
Yeah.
Nadine, do you have anything else that you would like to talk about, to ask?
I don't think for today. We might have to have Dr. Brandt back again another time.
I would very much love that.
We're fans of bringing people again.
I enjoy that. I enjoy that. I loved meeting both of you. And like I said, you said we've known each other for years. I mean, that is my expectation. So, you're just fast forwarding in time.
Thank you so much, Dr. Brandt.
Yeah, thank you very much for being here.
And lastly, how people can be in contact with either you, the clinic, anyone that might be able to coordinate the appointments.
I like to be a very, very visible and active surgeon. So especially since my offices are really in flux right now, and I'm kind of all over the place, like literally here, Philadelphia. So I have an email. I think you had the bar thrown up. So you can email me directly. That's my office phone number. I'm, typically I take about 12 to 24 hours to respond to emails. Weekends may be a little bit longer, depending on where I'm at or what my call schedule is. And then Tina Lee is my nurse coordinator. She is amazing. She is responsible for scheduling appointments and verifying insurance. So if you reach either one of us, if you want an appointment, I will always respond back and then just kind of forward your email to Tina to schedule. Since I don't have scheduling power, if I did, I would just be blowing up schedules everywhere. But most of the time you'll hear back about Tina inquiring about insurance and, when you want an appointment, what the appointment's for, and things like that. So either one are acceptable options.
Awesome. And are there surgeries covered by insurance? You just mentioned that, and I just don't want to live without having that bit of information.
Most insurances will cover the surgeries, actually.
Awesome.
Including Medicaid. The insurances that PA state Medicaid tend not to cover are facial surgeries, so facial feminization, which I don't do. I would refer out to that. Actually, a partner in practice of mine would do those, but most insurances will cover that. They often insurance companies follow the WPATH guidelines, or the World Professional Association for Trans Health guidelines. So typically for any type of top surgery, like I referenced before, it's one letter from a mental health provider. But really the difference between top surgery for trans men or non-binary folk, that to take into account non-binary folk who want a mastectomy, they don't have to be on testosterone for a year. That's a newer change in the guidelines, which I think is great, but you still need a letter from a mental health provider with experience in treating transgender clients. For breast augmentation, however, you do need to be on hormones for at least a year, ideally 2, but a year is typically enough. The reason being is because you need to allow for maximal breast growth from the estrogen to allow proper implant selection. Okay. You also need a letter from a mental health provider. For any type of bottom surgery, so that vaginoplasty for trans feminine folks, or the creating of the microphallus, or the metoidioplasty, or the full-length phallus with the phalloplasty, and hysterectomy, you need 2 letters from 2 separate mental health providers, and hormones for a year. Now, if you need a hysterectomy for a gynecologic reason, so if patients are having irregular bleeding, really severe pelvic pain, fibroids, things like that are conditions that you would do a hysterectomy for in cis patients, you don't need a letter actually, but insurance will cover all of those.
Wow, that is so great.
It is. Yep. And good to know, and good information to get out.
But I have not run into a problem yet.
Perfect. And hopefully you won't run to any problems. So let's keep it like that. Knock on wood.
Yeah, I know.
Well, thank you, Dr. Brandt, for being here, for your willingness to participate and to allowing us to get a little bit of your time.
Of course.
We know it's valuable.
I will always make time for things like this. This is what I really love to do, and this is what I've always wanted to do. So very passionate about my patients and my work. So
thank you for doing that.
Thank you.
Seriously, yes. Thank you so much.
Thank you both for the services you provide. It's truly valuable. The analysis, especially right now in a time where trans youth are being targeted very hostilely. From school legislation, state legislation, and on a larger level in certain states for accessing affirming care. I think the work that you do is equally, if not more, valuable right now. People are leaving adults alone now. It's the targeting, which is a shame.
Targeting the youth.
Teens have enough problems. I'm so glad I didn't grow up during Instagram. Like, I can barely handle Instagram now. Let alone, social media. Let alone, I feel bad for them, I gotta say.
Yeah.
So, so I really am grateful for the work that you both do.
Thank you so much. Well, everyone, I hope that you enjoyed this amazing, not interview, but just conversation. I did enjoy it. So I might just revisit just for
gonna watch the recording, Jonathan.
Yeah. So thank you so much, Dr. Brandt, and hopefully we will see everyone else next week. Bye.
Yes. Bye-bye.
Stay cool.